Hello, everyone, and welcome into December. Wow, 2025 is coming towards a close. Great to get to be with you here for SADS Live 172. Wow. I'm Mike Ackerman. I'm a genetic cardiologist here at the Mayo Clinic in Rochester, Minnesota, but I'm here on behalf of the SADS Foundation, where I've gotten to serve alongside now our new CEO, Walker Fromm, and his incredible team. Where it's great to be your family for those who are dealing with a SADS condition, and whether your condition is long QT syndrome or CPVT syndrome or ARVC, whatever your condition is where you have found us home, I hope we're a good home for you. We are trying our best to meet your needs, to stand in the gap with support and advocacy, to increase awareness, to do education, and let us know how we're doing. And if you wouldn't mind, consider making us one of your charitable contributions for your year-end giving. This is Giving Tuesday, as you know. I guess that's the new thing, right? The first Tuesday after Thanksgiving. And certainly we had much to be thankful for. I do, for sure. Wonderful Thanksgiving, wonderful with family, and got to fly. My son, Nicholas, took me flying, and my daughter, Grace, took her brother flying for the first time. So Jens had not been flying with her, and we had a great flying Friday. Maybe we'll post a video, but wonderful Thanksgiving. I hope you did as well. But now, as we come to year-end giving, would you think about us at www.sads.org or stopsads.org and go to that top right corner, hit the donate now, and give. Your giving made a huge impact. We had a lot of accomplishments besides being there to support you all. The ICD-10 codes, that's going to be big. Impact for our families with these conditions. We are preparing to celebrate next year the 35th anniversary of the SADS Foundation, since it was founded by our original founder and first president of the board, Dr. Michael Vincent. And so a new era is underway under our current CEO, Mr. Walker Fromm, and that handoff from Alice Laura for a long time to Walker has gone beautifully. I can tell you that with great confidence. Well, for SADS 172, besides your Giving Tuesday encouragement and partnering with us for year-end giving, let us look and dive into your questions. The questions last time during our gratitude week were incredible. I love them. You all just pose incredible questions. I try to give good answers. Remember, I do not give patient-specific advice. I cannot do that. I need to spend hours with my patients before I give them direct patient guidance to tailor their therapy, to make their diagnosis. And so we don't do that with your questions. What we do is take them and try to illustrate and answer the principles or the issues behind them. And if you extract something directly, then great. But this is, of course, not patient specific. And we start with Wero. And during the last live, a few questions came to mind. What is the main trigger mechanism for torsades, TDP, in people with long QT syndrome? Is it primarily a PVC falling on the T wave? Can bigeminy also act as a trigger? It makes me wonder, because I don't have long QT or CPVT mutations, but my QT is prolonged. Whew, that's a question. And I sometimes have bigeminy, especially when my heart suddenly speeds up or when I'm stressed. I also sometimes get PVCs with a short coupling interval. Wow, there's a lot to unpack there. A great set of questions. When it comes to, let's start with long QT syndrome, right? The trigger for that heart that is recharging in a pokey way is always a skip beat, a PVC, a premature ventricular contraction that struck the heart at exactly the wrong time on the downslope of the T wave to upset the apple cart and cause the heart to twist into a torsadogenic rhythm, or twisting of the points, as what torsades, the French word, means. Now, that PVC is not any ordinary PVC. It's a very rare kind of PVC that strikes the heart early, and that's why we call it at the cellular level early after depolarization. Now, long QT patients almost never have PVCs in bigeminy. Bigeminy is a term for every other beat is a PVC premature beat. Now, in your case, you're saying you don't have long QT or CPVT, but we have a borderline or prolonged QT. So we either have a borderline QT, which basically, who cares? It doesn't matter unless it's exaggerated in its QT prolongation by an exogenous substance, a drug that could be QT prolonging, an electrolyte abnormality that could be QT prolonging. And in that setting, we don't worry about PVCs basically almost ever. And the final mentioning of PVCs with a short coupling interval, that depends on what exactly we're talking about. So that's a descriptor of how close or how coupled is that skip beat, that PVC, to the previous normal beat. And there are short coupling intervals, and then there are short coupling intervals. And so you and your physician would need to understand whether it is short-ish, but who cares, or whether it is concerningly short as a coupling interval, and we need to care because that could be an pro-arrhythmic coupling. Well, that was a lot to get it started, and those were good. So thank you for your first question, because it's a new name to me, at least. Then scrolling down, remember, I take them in order, no cherry picking, no matter how hard they were, like that first one. Christina's asking about hormone replacement therapy, HRT, in perimenopausal women with CPVT, catecholaminergic polymorphic ventricular tachycardia. And as a general principle for all of my patients, like the one I saw yesterday with her LQT2 status, perimenopausal, is if your women's health specialist is suggesting that you would benefit from hormone replacement therapy for whatever reasons, whether symptoms, whether bone density, whatever those are, and I stay in my lane, and I don't pretend to know what all of the benefits are for HRT. So if that woman's health specialist is saying, I think you would benefit from HRT, I basically am never concerned about hormone replacement therapy and its potential agitation in CPVT, because basically there is no potential, zero risk, not concerned. Could there be in long QT? Well, of course, there's a theory for that, isn't there? Because we know that the arrival of estrogen and progesterone for a little girl going to a young adolescent female brings with it greater risk. So doesn't it make sense that why would I continue with hormone replacement therapy if estrogen is potentially QT agitating in long QT? It makes sense in theory, but in reality, if that woman is diagnosed correctly, treated correctly, I have basically no fear, concern, worry about hormone replacement therapy in a well-treated LQT2, LQT woman in general. CPVT, there's no interaction of theoretical concern. Same for Brugada. In theory, there is that concern in long QT syndrome, but that's probably of reality when you are undiagnosed and untreated, but no concern. Bottom line, if the women's health specialist thinks you would benefit from it, I don't have any concern about hormone replacement therapy. And as the SADS mentioned from Aaron as to your gift counts, and it does, and we thank you in advance for it. Danny's asking, can someone have a CACNA1C variant and not have Timothy syndrome? Oh, I love the question, Danny. Absolutely. And I think we have been confusing out there with calcium channel mediated mutations and what it equals. So wonderful discovery named after Catherine Timothy. I love her, a nurse, worked alongside Dr. Michael Vincent, our founder, and with Mark Keating, one of the great cardiovascular genetic scientists of our time, who discovered the root cause of not just LQT1, not just LQT2, not just LQT3, but also Timothy syndrome. That discovery paper showed mutations in the CACN-A1C encoded calcium channel as the root cause of Timothy syndrome. Now, that discovery does not mean that every calcium channel mutation is a Timothy syndrome one. In fact, most calcium channel mutations are not. Most have nothing to do with Timothy syndrome. There's a particular hotspot mutation that's responsible for the vast majority of Timothy syndrome. I think it's G406R, but that's from memory. I could be wrong on that, but it was an incredible scientific sleuthing that led to that discovery from Mark Keating and his lead scientist, Igor Splowski, the name from a while ago. Good friend. If you're by chance connected, Igor, shout out to you, my friend of old. Great detective work. But the majority of gain of function mutations in the L-type calcium channel cause not Timothy syndrome, cause type 8 long QT syndrome, a heart-only long QT syndrome disease, just like LQT1, without all of the head-to-toe manifestations, systemic issues of Timothy syndrome. So great question. Most variants in the calcium channel do not lead to Timothy syndrome. Debbie's sharing with us that she's on her 8th ICD. Wow, that's a lot. With 3 sets of leads. How long do leads last? Now, ICD, and we've had wonderful talks from our board member and my dear friend Charlie Barul about the state of ICD, and maybe we'll be due for an update interview that I can do talking about the state of devices in the care of patients with one of these SADS conditions. But there's a lot happening. The old way of doing an ICD, we have newer ways. We have not just 1, 2, 3, but at least 4 different ICD configurations if we need it. Now, remember, you hear me often saying that the vast majority of patients with long QT, CPVT, Brugada, do not need and should not receive an ICD. Because when you do give an ICD, sometimes you end up with ICD-related issues, like a lot of them, or leads in them. Now, these devices are incredible inventions by men and women. They have saved lives, but now we have to navigate the leads. So in Debbie's case, with these leads, how long do they last? Well, they can last a long time. I have patients who still are on their original leads, and those leads are now 25 years old. And we've done the battery replacement every 8 to 10 to 12 years, however long the battery has lasted, and just the same lead. Now, I have other patients who we didn't even get a year out of the lead, and then we encountered an ICD lead fracture or some type of problem with the lead. So short answer is it depends the state, but they can last a long, long time. Kelly's wondering, will there be any development in 2026 in research and studies for gene elusive CPVT patients? Oh, wow, good question. Yes. I can't tell you the details, but I am aware of work being put together from my dear friend Shu Sanatani and our pediatric CPVT registry, along with the international CPVT registry that I oversee with Arthur Wilda, and exploring, guess what, Kelly? Exactly that question. What do we know about gene elusive CPVT? Hopefully it'll get presented in May at the 2026 Heart Rhythm Society. So it's in motion. I can't share any of the details yet, but the effort is being assigned to that because we talk about CPVT1 all the time, and we should, because CPVT1 is the market share. it accounts for at least 2/3 of CPVT patients. And actually, that number is probably going higher when all is said and done. And if you really do have CPVT, it's the number that are explained by the number one gene, RYR2, is going to be north of 65%. But there's still going to be the remnant of genetically elusive CPVT, and we deserve, and you deserve, if you're one of them, to have us learn more about the behavior of that collective entity where we have not yet been able to find your monogenetic single gene explanation. It's in motion. It was a great idea, Kelly. Thanks for it. We'll give you credit for it. And my slide is advancing on me, so I don't want to skip the next one because it's Elizabeth's. What do I do when I feel I'm having a hot phase, but the ER never knows what to do? ICD did not shock and monitor did not pick up any arrhythmias, but troponin went to 14,000. I'm lost and exhausted. Great question, Elizabeth. And for many of you out there, you're probably going, what is that about? I've never heard about that. Well, that's because Elizabeth is not describing what happens in long QT, CPVT, Brugada, Timothy syndrome, because there's almost never a hot phase. What she's beautifully describing, although it's incredibly frustrating, is what we know in the world of ARVC, arrhythmogenic right ventricular cardiomyopathy, or more collectively called ACM, arrhythmogenic cardiomyopathy. And in her case, this hot phase is something that we see in patients with PKP2 genetic heart disease or PKP2 mediated disease, ARVC. Sometimes we see it in the desmoplackins. So if you're a DSP person, this might be your story. And we're learning in these entities that there's like a flare. And we don't know exactly the why, but remember in ACM, ARVC, there's sort of stress or distress between the cell-cell adhesions, one cardiac cell tethered to the next cardiac cell, and they're adhesed together through the desmosomes. And these mutations can create a fracture, if you will, of the desmosomal proteins. And there might be sites of the proteins that appear never seen before. And our body's immune system creates a reaction to that novel site and creates what we would describe as an autoimmune flare or a hot phase. And what do you do about that? Well, of course, if it's hot and creating arrhythmias, then we got to navigate the rhythm issue, and that's with the ICD. But the what to do about it if it has not given you a shock, do you go into the emergency department to see how much cell-cell distress is there, and the troponin leak or having an elevation in your cardiac troponins is an indicator that there is cell-cell stress, cell-cell death, cell-cell apoptosis, and so forth occurring, is challenging. I tell my patients if they're having a flare but not having a shock and it's navigating, then we just manage. We do have some patients where we're exploring and treating them with autoimmune strategies, immunosuppressants, chronically, and sometimes when they flare. And so it really would be something, Elizabeth, that the best thing I could say is you should really be seen by an ACM specialist. You should be talking with the ACM specialist about some newer treatment strategies for the flares that our program and other ARVC centers are doing. So don't stay lost. There are strategies that are being explored and done for these hot phases. Helen's asking me a wonderful question. And again, for most of you, if you're not ARVC, that hot phase and flare is not relevant to your condition. So I always try to remind you, in our community, some of the things are transferable across all of the diseases, while some of the things and issues are your disease uniquely and only. And for those, you can say, okay, not my problem. I'm not going to worry about that. You don't need to make something that's not part of your disease part of your disease with the anxiety that it may or may not bring. Remember, no anxiety. We don't do that. We live and thrive as best we can. Helen is sharing with me that today her ECG showed that her QTC is 493, and it's usually 470. So this result worried me a bit. First, no worries. We don't worry. Instead, we have to realize that that QTC number is kind of a barometer. And you know how the weather can change, and so can the QTC number. And what matters the most is kind of what is your zone? What is your range, if you will? Now, are there certain numbers that catch our attention that we want to figure out? Yeah, there is. And I think the 500 line has stood the test of time. Mathematically, in our program, the better line of information might be 515, but who cares about that? Let's keep the 500 line as the call to attention line. And I like to understand if my patient had been below that line and now is above it, why? Could it be natural moving about? Yes, it could. Or could it be a change, an exogenous exposure? What drug did they get put on? Did we make sure it was QT safe? What's their nutritional health? What's their sleep habit? Is there sleep deprivation occurring? That can stress the QTC. Is there an infection? That can stress the QTC. Is there sleep apnea that's been unrecognized and untreated? That can stress the QTC. So otherwise, if we're in our normal healthy state and it just happened to be above our norm, maybe see if it regresses back to the norm. So I won't worry. I keep an eye on that. And I do encourage all my patients to understand their 500 line status. Are they below it? Great. Are they above it? Did we know that? And that's why we're treating them pretty aggressively. Great. It's all good. Amy sharing that her father, her father died at a young age 30 from cardiac arrest, and they're not sure the why. And she now has had fainting spells since she was a child. Her sister has signs of cardiac dissection. Do you suggest genetic testing? We wonder if that's what happened to my dad. Amy, that's such a good question. First, so sorry about your father's passing. Probably now several years ago, but it doesn't matter. It's always fresh and can always be brought up to that instant moment of reflection and sadness. So I'm thinking of you. Now, the issue depends on what we knew about the circumstances of a death. So I always go back to the most important individual in a story like this, and that is the decedent. What did we know about his or her story? Was there an autopsy done? What did it show? If not, what were the circumstances? Was this the first? Does it feel like this could have been a genetic arrhythmia process, or is there other reasonable explanations? Once I have a handle on that, then I go to your story. And I have to understand, in this case, what are these fainting spells since childhood about? Because fainting itself is not a good warning in the sense that it's a common. So 25% of all humans will have quote unquote fainting spells. 25% of all humans will faint at least once before their 25th birthday. More than that in the females, less than that in the men. So a fainting spell by itself doesn't help me. Now, if I know about the fainting spell and you tell me it happens 5 days before my period, and if I get up too quickly, I get lightheaded and woozy and dizzy and tunnel vision, and then I sort of drift, but I don't actually faint. Sometimes I faint. Now I'm don't even care about that fainting spell from the standpoint of sudden cardiac arrest risk. Now, would I want to do some things to make that tendency less? Of course, but Danger, I'm not even thinking about it. Or did the person faint while sliding headfirst into third base after a successful triple in softball? Well, that's different. That doesn't sound like a normal, ordinary, who cares faint. That sounds like a danger faint. And if the story sounded like a danger faint, then we'd need to do a complete cardiac evaluation in you, regardless of the father's or the parent's sudden cardiac arrest. And then would I do genetic testing? Depends on what I would learn from that standard non-genetic cardiac evaluation. Debbie's asking, how safe is lead removal? That depends on a lot of factors. Depends on how long the lead has been in place, where the lead was positioned, what kind of lead was used. Is it a so-called single coil or one of the earlier version dual coils? Was it put in at an older age, at a younger age? And so this is one that you would want this carefully reviewed by your ICD specialist. And there are extraction centers of excellence. And if there's been a lead in place for a long time, greater than 5 years for sure, it should be done at a center of excellence, really, to make sure they're dealing with the chance. And it's a real chance, not a high chance, but a measurable 0.5%, 1 in 200 chance, 1 in 100 chance of an extraction near catastrophe, an extraction perforation. And so you would want to have it done where that threat is neutralized to as low as possible. And then more importantly, they have a ready plan to execute if you were to be that 1 in 200 person, so that we could get that person back pronto. And have any of my patients had an extraction perforation? Absolutely. Thankfully, they are doing great despite that close call. Debbie's asking, oh, she gets multiple today. Do GLP-1s affect long QT? I'm going to need to write a paper on this because I think we're probably ready to do this. I think it's safe to say I may have more long QT patients under concomitant GLP-1 agonist therapy for weight loss or metabolic syndrome or type 2 diabetes or whatever is the indication for their GLP-1 agonist. I think there's basically no QT signal of risk. They're not on the QT drugs to avoid list, www.crediblemeds.org. That's good. But sometimes it takes a while post FDA approval to see a signal emerge. And they've been around for now a long while and no signal of concern is emerging. So I have zero concern, including for the 2 patients I saw yesterday who were exploring starting on a GLP-1 agonist for a GLP-1 inhibitor for, now I'm blanking if it's an inhibitor or an agonist. Well, it's the GLP-1 drug for weight loss, and the common trade names that people know of. We're talking about Wegovy and Ozempic as examples. Maricia from Instagram, so join us from that social media platform, is asking, is sertraline safe for long QT? Now, sertraline, as many of you know, is an anti-anxiety, antidepressant medication in the category of the so-called SSRIs, the selective serotonin reuptake inhibitors. And as a general rule, first, are those SSRIs like sertraline, like Zoloft, like Celexa, like citalopram, like Prozac, like fluoxetine, don't want to leave anybody out, they are all on the credible meds list that I just mentioned. So should they be avoided? Well, it depends. And that depends on what is your long QT risk, how well is your long QT status treated, how has it behaved, and what is the level of disease-related or disease-unrelated anxiety and depression that you're navigating through in your mental health journey. Having said that, I can only tell you that in my program, I have lots of patients now, with having over 2,000 patients under our watch who are struggling with anxiety and depression, sometimes related to their disease, most often just related to this thing called life. And if do I prescribe those medicines? Never. Do I partner with their mental health specialist to come up with the best strategy? Yes, always. So what I do in my program is I ask the mental health specialist to say, based upon what you're observing, based upon what you've tried, cognitive behavioral therapies, other strategies, and you now think medication strategy is necessary, helpful, which medicine would you find best? Then they tell me that medicine, and I say if we think we have wiggle room. In other words, I don't want them picking a QT clean antidepressant if they hate that antidepressant. If they say, I don't even think it really works that well, but it's not on the list, so let's use that one. I don't like doing it that way. I want them to pick from a strategic standpoint based upon what they're trying to treat, and then us come together. And sometimes I'll say, you know what? The QTC is consistently over 500. We just do not have room for sertraline in this situation. Now, have I ever intensified a long QT patient's treatment to install a defibrillator for ultimate protection so that the psychiatrist could more aggressively treat their depression, their anxiety, their schizophrenia with drugs that are potent QT drugs on the hit list, normally would be avoided? And the answer there is yes, I've done that. And so it really depends when we're trying to treat the entire patient, what strategy makes sense for him or her. Carly, oh, I recognize that name. Hi, Carly. Dealing with asthma nebulizer type meds that work okay for Nadolol for our 3-year-old who has long QT. What's the best protocol for long QT and respiratory issues? Good question. So as we know, what is it? About 7 to 10% of humans have concomitant asthma or AHR, airway hyperresponsiveness, twitchy airways, wheezing syndromes, viral induced bronchospasm, whatever is our descriptor. And so it makes sense that the same population of our long QT kiddos might have those newborn toddler childhood issues. As a general guide, I have no fear of any of the albuterol nebulizers in my long QT patients. There was an early paper published about that. Albuterol is on the QT hit list. Albuterol being adrenaline-like is why it's on the list. Practically speaking, I don't worry about it and have treated hundreds of kids with their inhalers. Now, do we think, or is it possible that the beta blocker, the ones that we like the best, Nadolol or propranolol, could aggravate asthma, could increase bronchospasm, the twitchy airways, in the setting of their triggers? Yes, that's possible. And do we sometimes come up with a beta blocker free treatment strategy so that we get rid of that beta blocker side effect of aggravating the asthma? The answer is yes, we do. And that is the beta blocker alternative of videoscopic left cardiac sympathetic denervation, which has no effect on airway health. And so once in a while, that is a guidelines recognized indication for denervation surgery, is if the patient's not tolerating the beta blocker because of beta blocker side effects, in this case, beta blocker aggravation of their asthma. So my strategy kind of then depends on, what did I think about the long QT risk? Do I really need that child treated, or would there be room to explore a beta blocker holiday to see how much the beta blocker is in fault to blame for the airway issues? Or if there is no room for that beta blocker holiday because the QT must be treated, then do we explore other asthma therapies? Do we let there be the albuterol inhaler to use, which I would support? So lots of things that should be carefully reviewed with your long QT specialist. Now, I see where we are on the hour, so I'm going to give the last one to Cindy. It's at the here. I recently lost my 19-year-old son. Oh, I'm so sorry. In August from sudden cardiac arrest due to WPW. Is there any genetic testing I should get done for myself, other children, and my husband? First, so sorry. Thanksgiving was so painful for your family, Cindy, with this being way too unacceptable, fresh, and raw. So first, our condolences to you. We don't hear a lot here at SADS Foundation of the entity WPW, but more and more we find families who find SADS Foundation as your home. And so we love that we're your home. Now, WPW or Wolff-Parkinson-White is mostly not a genetic condition. There's very few reasons to do genetic testing for pure isolated WPW. Now, I'm assuming that by this diagnosis, that meant that your son was diagnosed with WPW during life from an ECG obtained because of symptoms. Often palpitations would be the symptom, or sometimes a screening ECG will expose the so-called delta wave or pre-excitation, because we have a very hard time, almost impossible, identifying WPW at postmortem, at death. So I'm presuming it was diagnosed during life, and yet the tragedy of WPW triggered sudden cardiac arrest and death occurred. If an autopsy was then done and nothing else was found, and specifically there was no thickening of the heart muscle, because there is one form of genetic heart muscle disease, a hypertrophic cardiomyopathy, that can also have WPW. It's actually a glycogen storage type disease from a different gene that we don't talk about. The name of the gene doesn't matter. That, or there's a congenital heart malformation called Epstein's anomaly. Short of those two things, if there was nothing, there's almost no reason to do genetic testing. Would it be reasonable as a precautionary measure, given what you've gone through, for mom, dad, and siblings of that 19-year-old to get an ECG to see if they by chance do or do not show WPW, which is probably present in, I might be wrong in my number, let's say 1 in 500. I could be off, so we need to fact check that one. That's reasonable. There certainly is no downside to getting an ECG in that setting. Well, here we are. Now at the top of the hour, incredible questions, some of them coming from incredible pain, I must note, and so sensitive to that. But we bring SADS 172 to an end, and we will be joining you for SADS Live 173, almost the last day of the year, Tuesday, December 30th. So by then, for those who celebrate Hanukkah, that will have come and gone, so happy Hanukkah. There will be those who have celebrated Christmas for our Savior, Jesus Christ, for those of you who celebrate that season from the perspective of Christianity. For those fellow believers in Christ, Merry, Merry Christmas. But to all of you, as we bring December towards a close, I hope this month is a special one for you and your family. I will see you on the other side of Hanukkah and Christmas for SADS Live 173 on Tuesday, December 30th. Until then, blessings to all of you.